This presentation is based on the Gonstead technique for pediatric adjusting and care. It is not a comprehensive pediatric presentation for Gonstead. It is a brief overview. I'm going to cover some of the highlights of how Gonstead technique approaches pediatric care. How do you adjust a 1-year-old child's Atlas ASR? I want you to take a minute to think about this question and then answer it, and then we'll have discussion on this when I present this lecture during lecture time. One of the important things to remember when adjusting pediatric spines is that the infant and pediatric spine are not anatomically the same as an adult spine, and we must take these differences into consideration when adjusting the pediatric patient. This slide has two x-rays on it. The one to the left is an infant or pediatric film, and the one on the right is an adult film or adolescent film. It's a fully formed spine. What I want to point out here primarily are the angle of the facets. On the left, you'll see the pediatric facets are more horizontal, and as the spine develops and grows, those facets become more vertically oriented. Very important to remember when doing our pediatric adjusting. Our pediatric adjusting has much more P to A as an emphasis than we're adjusting an adult spine. Again, the same picture demonstrating the difference in the facet angles for the the adolescent versus the infant spine. Again, facet angles are very different. Here's a picture of an infant spine. We'll test your radiology skills. A 2-year-old involved in an automobile accident. The mother found the baby slumped in the car seat. The child has continuous crying and won't eat. What is wrong with this spine? And this spine or this patient eligible for chiropractic care, or do they need immediate referral? What we see here is a very common presentation for small children that have been in car accidents or flexion injuries. They develop what's called a pseudo-subluxation in medical terms. We see a lot of anterior translation of C2 on C3 and C3 on C4. There's much more flexibility in the infant or child spine. They can show pseudo-subluxations like this, but it is a normal variant for them. But this is what makes them great chiropractic patients. We could work on correcting the spine before these segments adapt to this position, develop long-term subluxations, and probably lead to premature degeneration down the line because these segments were not corrected as an infant. Here we have two films. The film on the left is a normal cervical curve for a small child. You can see the anterior and posterior bodies are very much, the line of those is very much in integrity. George's line also has not lost any of integrity. When we look at the film on the right, we see that those lines have lost some of their integrity, where there is some stepping, anterior stepping in the upper cervical spine. Again, in a pediatric spine, this is a fairly common presentation after a trauma, and this is why they make great chiropractic patients. Here is another picture of a spine of a small child. Here it says a 2-month-old. This child's probably a little older than 2 months old based on the maturity of the spinal segments. But the patient rolled off, fell on the floor. And you can see again, this is what's called a pseudo-subluxation, and it mirrors anterior seepage or facet injury. And again, it looks pretty daunting on the film, but this is something that can be a common occurrence in a pediatric spine. Now we're going to move on to Gonstead pediatric analysis and adjusting. Pediatric adjusting, in particular the cervical spine. When we adjust the cervical spine in Gonstead for infants and young toddlers, we are only going to use a P to A thrust when doing this adjustment. This is because of the angle of the facets And because the unsnate processes are very immature, we do not want to stress them or put any rotation into them when we're adjusting. So we primarily use our P to A adjusting. Motion palpation for the infant is done in a variety of ways. These motion palpation techniques are probably covered mostly in your pediatric class, but these pictures here demonstrate some of the techniques used to analyze an infant's spine. You have to use a contact that matches the patient's body so you could actually feel the individual segments. You have to do some passive motion, especially in the pelvis, because the infant does not know how or cannot move their body in the position you need them to analyze the pelvis. The atlas analysis. Atlas seems to be a very common segment adjusted in the pediatric population, especially the infants. In clinic, I see most of my students, when they are adjusting infants, they are very focused on atlas. I'm not sure why they are so focused on atlas, but it's an easy segment to, I guess, contact and adjust. But to analyze it properly, we're looking for suboccipital swelling in the area of the capsules around the lateral mass. We're looking for a rotation restriction. We're also looking for a lateral flexion restriction. This is done by placing your chiropractic index fingers on the patient's atlas and laterally flexing them to the right. And when we do that, we should feel the atlas kind of slide away from our finger. When we laterally flex to the other side, it should do the same. You should feel atlas translate to the left and to the right as you laterally flex. You could use the righting reflex, where you hold the baby up in your hands and tilt them to one side and see if they can right their head. If they cannot, that may mean that there's an open capsule on that side, indicating the side of the subluxation. And we could also use some feedback from the mom on if the baby has a preference on side of breastfeeding to help maybe guide us in determining which side is subluxated. There are a variety of ways to adjust an infant or young toddler's atlas. We can use this technique from newborns all the way up until they can sit up in the chair on their own. On the left, you see a cervical chair atlas setup on the infant who is sitting on the table and is wedged between the doctor's legs. You see her contact on the atlas with the thumb and her stabilization of the cervical spine with the opposite hand. And she will laterally flex just enough to isolate that side of atlas, and it will be a lateral to medial S to I thrust, just like we do on an adult. But again, we make the thrust appropriate to the patient, and we make our contact appropriate for the patient size. Especially as we see here on the right-hand side picture, this baby is a little bit smaller than the one sitting in the chair. This one's a little guy, and she's using a finger contact on the atlas TP, with the baby in a side lying position. The baby can be placed right across your lap or across the parent's lap in the side lying position, and you follow the atlas down from the TP, bring it to tension, and it's a set and hold. The AS occiput, often a presentation for a small child or infant, could have a variety of causes. The one cause that can happen is from the birth trauma, especially if it's a challenging birth or they have a brow presentation or they have a forceps delivery. That trauma to the cervical spine can be pretty significant, and that's why we should check all newborn children. The newborn or infant may present with hyperextension of the cervical spine, raised chin, hypertonus of the posterior cervical muscles, kind of in this stargazing type posture. And a toddler with an uncorrected AS occiput may develop a cervical kyphosis as a compensation, because if they're stuck in the extension position of occiput in the AS, what they will do is they will then compensate by bringing their cervical spine into a kyphotic curve to bring their eyes level with the horizon. Could lead to long-term compensatory changes in the spine. And I had an adult patient who had a lot of developmental issues when she was very young, and she had a complete kyphosis of the cervical spine. And when we did her x-rays, her occiput was still in an AS position because of that. So my theory was that that was an AS from birth or very early on in age, was never corrected, and the cervical spine completely adapted and created a kyphosis to compensate. These patients with an AS occiput, they may demonstrate head banging activities. This is not the type that you may see with a child who's on the autism spectrum, but this is the type of head banging where they're typically trying to bang either their forehead or their top of the head down. They typically put their hands on the wall or on the floor and start tapping their head. This is innate, trying to tell them to, hey, try to put my own occiput back in place because it's stuck in an AS. If it is not corrected, it can cause major neurological complications with the infant. The chiropractic analysis for the AS occiput it uses all of our Gonstead criteria to determine the level of the subluxation and the fixation. We use our nervoscope looking for a break in the upper cervical spine. We will do our static palpation. We're looking for suboccipital swelling, especially medial to the mastoid process. We will do visualization. We'll observe the patient's head, seeing if they have a pattern of hair being worn off the back of their skull from rubbing, or if they have a stargazing posture with their head and eyes gazed up. We will do our motion palpation for the AS occiput. We'll use the appropriate size condyle block and we'll motion the head and the occiput A to P and S to I, very similar to the way we adjust it, but you need a condyle block to do this motion properly. Okay, there'll be restriction on this motion and tenderness in the posterior occipital atlantal junction. Lateral cervical film shows that the posterior arch of atlas is up against the occiput or very close to it in the AS presentation. We could also do a lateral cervical flexion X-ray study showing that when we put the patient into flexion that the atlas does not separate from the occiput. The correction of the AS occiput, again, you've probably learned this in special pops or your pediatric class, but it was developed from the Gonstead system. The arrows here, the pink arrows, show that that condyle block is under the patient's cervical spine. We have to use the condyle block to make this correction. Without it, the cervical spine is unprotected and you will cause further subluxations or even worsen the effects based on a poor adjustment. On the left, the doctor is using a two-hand approach, double thenar on the frontal area, pushing S to I and A to P on the patient here. On the picture in the right, using a two-hand, helping stabilize the occiput as she pushes A to P and S to I on the frontal bone. There's a little lift on the occiput, but also driving and stabilizing on the condyle block. When the patient gets a little bit larger, you could actually do this adjustment in the cervical chair with the patient sitting on the table between your legs, kind of like we saw the atlas adjustment earlier. You put the condyle block between your abdomen and the patient's cervical spine, and you can make the correction that way as well. Here we have a couple pictures of other upper cervical corrections. On the left, we have a PS occiput with a thumb contact. It is made just like we do for full spine. It's a P to A, S to I, and lateral to medial adjustment with our thumb on the mastoid groove. On the right, again, is the same picture as earlier, showing the atlas thumb contact, and the thrust is S to I and lateral to medial. When performing your analysis of the cervical spine or anywhere in the spine on the infant, the very small child, our digital palpation for the tissue changes should be skin on skin. We have to go skin on skin. These are very small, very delicate spines, and the soft tissue is very delicate as well, and we have to use the appropriate contact to meet the needs of the patient. We're going to look for our motion palpation restrictions, and we're primarily looking for these restrictions in the sagittal plane only because that's the way we're going to adjust this patient. We do not thrust lateral to medial into a lateral flexion position and shear across the facets. This is a spinous contact P to A adjustment only. We do our visualization. We could look for spina bifida, scoliosis, any malformation, masses, and lesions. Same things we look for in adult, but we have to have the patient with their skin exposed so we can see all this. We cannot do this through clothing. The thoracic adjusting, similar to the cervical adjusting, we use the spinous contacts as the contact point, segmental contact point for adjusting, especially on our infants. The TPs are very small, they're very immature, they're difficult to contact, and they are altered in their position because their secondary ossification centers have not grown in yet. And as you can see in this pediatric x-ray, you can't even visualize the transverse processes yet. So this is why we stay on the spinous processes. They're much more dense and they're much stronger than trying to get out in the TPs of the patient. Here you see some pictures of the infant being adjusted. These are actually pictures that I'm showing you of all this pediatric adjusting are pictures of Dr. Claudia Onrig many years ago, and that is her dad, Ernst Onrig, holding the baby here. So it's taking two people to do this adjustment. She's using her pinkies, again, fitting the contact point with the segmental contact point. It's a P to A, I to S adjustment on this, primarily P to A with the pinkies. As she moves down into the thoracic spine, you can see the double thumb contact, again, making the contact fit the contact point for the spine. And again, this thrust is P to A on that infant. We're moving on to the pelvis. Motion palpation of the pelvis for the infant is all done passively. A great way to do this is with the patient prone on the table, actively lifting and lowering their leg to feel the motion palpation of the SI joints. We also do look for edema, and we look for restriction in 3 different areas. We divide the SI joint into thirds. We're looking for the upper, middle, and lower boot. We're looking for edema in those areas as well as our restriction. And this is where we'll find our edema, and these correspond to different types of listings. Edema in the upper part of the SI joint is indicative of a PI fixation. Edema in the medial aspect of the joint is indicative of a EX misalignment, and edema in the lower part of the boot is indicative of the AS subluxation. The doctor here is doing a leg check on the patient here. He's checking to see the leg length, the reaction to him pulling on the legs, whether they'll straighten all the way out. He could also be observing the toe in and toe out. Even though this is one of the tools with this infant patient, it's not the definitive way to determine the subluxation. The subluxation has to be found at the level of the subluxation, which is the joint, typically the pelvis here. We must have restriction in our instrumentation reading there. This static leg check just helps maybe confirm the misalignment that we're looking for. Just like we do visualization of the adult pelvis, we do the infant pelvis the same way. To do this properly, we have to have the diaper off, so you need to be cautious of that when you're doing this visualization for the infant. It's very important that we do this because, again, sometimes that MoPal might be very challenging on the infant, but we could also use our visual clues as well. We're going to compare the left to the right side. You know how to do this. We're going to compare the gluteal fold. The AS ilium is the higher glute fold. Okay. The lower glute fold would indicate possibly a PI fixation. We can visualize the mass of the gluteals. The I-end side, the glute is wider and flatter, just like the adult. The EX side is narrower and it says fatter, but it's more pronounced, it has a sharper curve to it. And here is a brief visualization of that. And toe out and toe in could also be indicated. That's similar to what the doctor did in the picture because infants want to curl up and go into a contracted position. He was just pulling the legs a little bit straight to see what the legs presented like. Also allows you to see the glute folds on the infant because if they're moving around and squirming, that also helps kind of straighten the legs out just a bit so we can make these observations. Yes, babies' butts are cute. In class, you actually get to vote on which one has the cutest bum. Adjusting the infant pelvis. The infant pelvis is adjusted very similar to the way the adult pelvis is adjusted. We can adjust infants inside posture. It's just a modified side posture technique to make it work for the infant. As we see here, Dr. Onrig has the baby inside posture. I believe this is probably a sacrum setup. She has her thumb on the baby's bent leg for stabilization, so she does not use her body here. She's just using her thumb to stabilize the leg, and a fingertip contact. She's also stabilizing the baby just like we do the adult to help control the patient on the table and to get our traction. And then the thrust will come right through the fingertips as she brings the patient to tension with her thumb. Okay, one thing we do in the Gonstead technique, not only do we analyze the sacrum, is that we also analyze sacral tubercles or sacral segments. Because the segments of the sacrum don't even begin to really fully fuse until 16 to 18 years of age, it may not be completely fused until 30 years of age. Sometimes these segments never completely fuse. They stay with like a rudimentary cartilage in there, and they still have a disc in there. They don't completely ossify. And in the study that I've referenced below here, the persistent disc study showed 61% of the subjects had the presence of a persistent disc in the sacral and coccygeal segments. So it's not uncommon. It's actually very common to have that persistent disc in there. And because of that, these segments stay slightly movable. And in the infant and in the growing spine, these segments move a lot. When I say they move a lot, when you mopel them, you don't feel a lot of movement, but they have the ability to subluxate, as we'll see in the next few slides. Again, our examination of sacral subluxation is similar to our examination in the rest of the spine for chiropractic and Gonstead. We do our instrumentation. When we do use our instrumentation on the spine, we always glide this nervoscope all the way through the sacrum, through the SI joints, looking for our break. We do static palpation on the cervicals. We go to the sacral tubercles, and we're looking for edema on each individual tubercle, and that's one of our analysis, is the static palpation. Edema right on the tubercle, a little puffiness around it, or perhaps some tenderness. The motion palpation, when we do this patient and we try to push P to A on the sacrum, we will feel it kind of stuck. It should have a little bit of a glide through there, because even when you're pushing the sacrum, trying to push it P to A, it should have a nice little glide or springiness when doing that, giving between the SI joints. But when there's a subluxation at one of the tubercles, when you go to push P to A, you can really feel the difference. It just feels like it's jammed. It will not want to go into that P to A motion. In our x-ray of this small patient, our lateral film is key because we can see on the film what a posterior sacral tubercle looks like, because there'll be an open wedge at the posterior aspect of this segment. And we'll see that on the upcoming slides. In the Gonstead technique, we have an entire book of Gonstead case management. This book was developed over 55 years of Gonstead's practice and includes pediatric care. And some of the things that he found very common with sacral subluxations in infants and children are these. The patient often could have an asthma presentation, particularly a wet asthma, when they have an S2 or S3 subluxation. And oftentimes this is associated with enuresis, in particularly nocturnal enuresis. I had a young patient who was almost 4 years old when she presented to the clinic. I had taken care of this young child when she was 3 weeks old. Her mom took her in to get her spine checked. The mom and the grandparents were both patients. So this young lady was taken to my practice at 3 weeks. I adjusted her and didn't see her for another 3 years. When I did see her at almost 4 years old, the chief complaint was enuresis. The mom brought the patient back to me because she remembered she had either read or heard something at the practice that said that chiropractors often have good success with treating kids with enuresis. So she had already been to the pediatrician. The pediatrician really didn't have an answer except for maybe some medications for the young girl. So she took her in to see me. And upon my palpation of the patient, I noticed that the left SI joint was extremely fixated. The sacrum on the left side almost felt like it was even with the PSIS. Normally we have that little dip from the PSIS. We're going, as we palpate, we can kind of roll off the PSIS medially and it dips in towards the sacrum. But when I did this palpation, that was not the case with this young lady. It just felt like it was straight across. And I said to the mom, I don't usually take x-rays on patients this young, but I believe there's some information on the x-ray that's going to help me care for your daughter. So she agreed, and we took our x-rays. The x-rays are modified for a small patient like this. Instead of we do take our A to P film in one view with shielding and all of the compensating filters to protect the young lady. We do take our lateral film, but because she has such a small spine, I do not have to do this in 2 exposures. I actually do my lateral film in 1 exposure because she's so small. I could still visualize my disc spaces just fine because of the size of the spine. When I took the picture, much to my surprise, this little tiny sacrum on a 3-year-old, almost 4, had 6 millimeters of posterior rotation on the left. That is a lot of rotation for an adult. It's an a large amount of rotation for a small child. And I'm glad I did take the film because that's exactly what the motion palpation and static palpation was giving me. And I also noticed that her S2 tubercle was posterior. So I was glad to find that because it does coincide with the issue she was having, and I knew that if I made the correction to that, more than likely she has a really good chance of recovering completely from the enuresis. Took care of her over a couple weeks, 2 or 3 weeks period. You typically do not adjust these children very often. You put some time in between the adjustments. Maybe if it's twice a week, it'd be like a Monday, Friday, or maybe even just once a week because these little spines need time to adapt. Anyway, within the 3rd week, she was completely pretty much down to maybe only bedwetting once a week. And at the end of the month, she had stopped bedwetting for the most part. An occasional accident. The mom took the young girl back to the pediatrician and for a follow-up visit on her enuresis, and the mom brought her back, says, well, how's she doing? She goes, well, her enuresis is gone. She's like, well, what happened? She goes, I took her to the chiropractor. She goes, well, what did the chiropractor do? He goes, well, he found the nerve pressure. And when she said that, the pediatrician blew up at her and stated that there's no way the chiropractor can tell if there's nerve pressure on the spine. He'd have to do a nerve conduction study. He'd have to stick your young daughter with needles and pins all over the place to do the nerve conduction study to know if there was nerve pressure. And I looked at her, I said, so what did you say? She goes, at that point, I knew it was a lost cause. I knew where she got fixed, and I was just done with it at that point. But we had very good success with it. Okay? There are some other issues that are seen with sacral segments and coccygeal subluxations. These are more anecdotal from my practice. Issues that I've seen repeat themselves with these type of subluxations. The first 2 I have seen as well and also come from the Gonstead notes. These 2 are more anecdotal from my practice. Allergic responses, kind of going to the asthma thing, affecting the respiratory system. A lot of allergies. Colleague with an S3 subluxation developed a horrible welts all over his body, a rash that would come on every day. He couldn't narrow it down to foods or a particular subluxation that he could find or environment or whatever. Came to a Gonstead seminar and one of his buddies checked him out. He goes, you know what? He goes, I found a subluxation at S3 on you, on an adult. He ended up adjusting S3 and the allergic response that he was having with all these whelps all over his body subsided almost immediately. The next couple of days, he goes, I feel great. You saved my life. He goes, I don't think I could have continued like that. I itched so bad. I was breaking out every day. And just needed a new set of eyes on the case and someone who's willing to look a little more closely at the sacrum. And it was an S3 subluxation on the stock, and it did really, really well. In autoimmune issues, I have seen this one with coccyx injuries. I've had 3 patients who have had coccyx injuries in their life have developed autoimmune issues. 2 of them developed MS symptoms. I don't know if they officially had MS, but that's what their doctor said. But when they started chiropractic care, we started adjusting them. Now, I was not adjusting coccyx, but I was adjusting their spine. Their MS symptoms went away. MS does have the ability to go into remission, but these ladies started to see an immediate change when we started chiropractic care till they were symptom-free and stayed symptom-free for years and had very good results, but they both had coccyx injuries. And the third one was a patient with scleroderma. She had scleroderma that was advancing pretty rapidly. The lady was not pleased with the medical treatment that she was receiving, so she decided to take her health into her own hands. and was counseling with some clinical nutritionists, so she cleaned up her diet and did some stuff to try to support her body and try to reverse the effects of the autoimmune response. And she also started chiropractic care. But one of the things she did have previously in her younger years was a coccyx fracture and developed autoimmune issues. So I don't know how much merit there is in that, but it's more anecdotal. But I have seen more than one patient with that coccyx injury develop autoimmune problems. This is an x-ray of our classic sacral S2 subluxation. You can see that the S2 segment has gone posteriorly to the S1 segment. It looks a lot like a BP orientation, which essentially it is, but at the S2 tubercle. The arrow is obviously pointing to the wedge, and the way we correct this is just like we correct a BP sacrum. We take an S2 contact and we thrust P to A and S to I because we have to take into account that cartilage or that disc that is in there to make this correction. These do occasionally audible because when we're pushing P to A and I to S, we can audible through the SI joint, and I don't know if the disc in there audibles or not, but we could definitely audible while pushing it between the SI joints. These corrections usually go very well. You can do this one prone if you need to, like we do our possibly a BP sacrum, or side posture with the fingertip contact on S2. Here are some infant corrections for sacral segment subluxations. In Gonstead, especially on the infant, we just do not contact the sacrum in general. We find which tubercle we're going to adjust and we contact it that way. The picture on the upper left is a thumb contact for the side posture push move. The picture on the bottom right is a fingertip contact for a pull move. It's called a pull move just because of the contact. She's stabilizing with her thumb on the patient's leg. But again, we have to make our contact fit the patient's segmental contact point. Another way this can be done is with the patient prone, either across your lap or across the parent's lap, and we make a double thumb contact on the sacral tubercle, and we can push P to A and S to I on it that way. I got a little ahead of myself. We could see the double thumb move here on the sacrum. And then on the bottom picture, you can see this one's a toddler, a little larger than an infant. You see Dr. Onrig taking a thumb pisiform contact. If you notice, her right arm is extremely S to I because it's matching the angle of the sacrum there. If you notice, this little person is on the flat table, but they are also laying on the headrest pillow. What we're trying to do is raise that sacrum up just a little bit. It makes it easier to access so they're not in a deep lordosis when we make this set, and it also helps to really support the lumbar spine because we're going to end the ASIS as we thrust P to A and S to I on this. This can be done on the high-low, but the problem is the little person can't reach the headpiece and their pelvis won't be on the pelvis piece, so we could do it here with the pillow. Okay, adjusting considerations for the infant and pediatric patient. No rotational moves on children or on anyone for that matter. Gonstead technique does not have a rotational move in the spine. All of our adjustments are P to A and I to S. Particularly this is important on the infants and the young children because the uncinate processes are still very immature. No thrusting into lateral flexion from C2 to T2 because the uncinate processes are immature. We have to wait till those uncinate are mature before we could put that patient in a cervical chair type position. I can adjust the patient in cervical chair, but there is little to no lateral flexion. Again, the thrust is P to A and I to S. It's different than a full spine type move where you laterally flexing, you kind of come from the side. In the Gonstead with the type of contact we make, there's very little lateral flexion. The thrust is P to A and I to S. No long lever moves, again, which Gonstead does not have for the spine. In the pelvis, I guess the only sort of long lever move is when we do an AS occiput. We're contacting the frontal bone and not anywhere near the occiput. But that's why we use the condyle block to help support the spine, and we really control our impulse on that. We must use our spinous processes when adjusting our infants and toddlers. The TP contacts can be made starting over 6 years old, but before that, spinous is only. Like I had mentioned all along in the slide presentation, you must make your contact point match the size of the segmental contact point on the patient. And as you know, in an infant, you may be down to just using pinkies for your contacts in the cervicals or in the thoracics. You may even use a pinky contact in the thoracics backed up by your fingers to push PED A and I to S, whatever it takes to match that contact point. No broad contacts in the sacrum, specific sacral segments only, like I've shown in the previous few slides. We're looking to see which sacral tubercle needs to be adjusted, and that's where we contact it. No anterior moves. There are no anterior moves in Gonstead, and there's definitely no anterior moves on a pediatric patient. It's too broad of a contact, and secondary ossification centers are still forming, so we do not use this. And we limit our thrust. You could always thrust a second time. Remember, infants and pediatrics are extremely flexible, so you have to bring them into tension, but it sometimes feels like it's forever to get there, and you got to impulse through there. If you don't get it, you could always try again. Don't overdo it on the pediatrics. Take it slow, and you'll do great. The next two slides are questions, hitting some of the highlights of analysis and adjusting the pediatric, particularly the infant and toddler patient. Okay, and here's just a cool picture in vitro. What I want to remind you of is don't be afraid of the little patients. They're little people. You have to just adapt your technique to fit their size. In Gonstead, we use the same technique on the infants as we do the adults. We just modify them. Our lines of correction are somewhat changed in the infant and toddler patient. And in Gonstead, we do thrust. We do have an impulse when we make these adjustments. Again, modified to fit the patient. And we can make it happen. Oftentimes in that pediatric spine, it'll surprise you what type of audible it makes. What also surprises me is the first time I get a pediatric patient who's never been to a chiropractor before, it astonishes me how subluxated these young kids are. You figure these are young kids, they haven't set up a lot of patterning in their life, they haven't had a lot of trauma and damage compared to an older person, but boy oh boy, those subluxations do start really young. And we want to make sure that we keep the spine clear, keep the nervous system functioning at its best. So I highly encourage you, even if you're not going to have a quote pediatric practice, that you have a family practice, and that of course includes pediatrics. Never marketed myself as a pediatric practice. I marketed myself as a family practice, and we had plenty of kids in there. Although I'll tell you, the first 5 years of my practice, I had very few kids in the practice. I moved into a new office space, and I had my CA, who was a high school intern, interning for her allied health sciences portion of her class. So she interned in my office, and she's also a very good artist. And I said, hey, I'm going away on vacation. You and the other CA, you come in and do all the work that you need to do, catch up on stuff, the billing and the cleaning and stuff. I said, also, can you draw across the front of our front wall where the reception desk is? I said, can you draw out the word chiropractic? And I said, can you do it in animals? So she said, no problem. When I came in, she was 3/4 of the way done. She did this absolutely beautiful jungle scene of the word chiropractic spelled out with animals and jungle trees and stuff. It was amazing. What was even more amazing was when my patients came into the office after she had completed that artwork, they're like, oh my gosh, you take care of kids just from the artwork on the wall. And I'm like, you've got to be kidding me. I have an entire section of the bookshelf over here that says pediatric chiropractic. But it was the drawing on the wall that drew people's attention more than anything else. A couple of things that helped build my practice, and they were unsolicited. I had a patient come in to the office, again, not until 5 years in practice. It just seemed, the mojo seemed to hit once I moved into the new office and put that darn sign on the wall. Gentleman comes in, he says, and I was putting out the plant in the front office because it was still a new office and I was given a plant as a gift. He walks in and I'm standing right at the front door. He goes, hey, how are you? I said, he goes, are you the doctor here? I said, yeah. He goes, hey, brought my kid in. He's got ear infections and I heard chiropractic can help. I was like, where did you hear that? He goes, well, I've tried everything else. We've had 7 or 8 rounds of antibiotics in his first 15 months of life and no one's helped him. And I figure I can't lose by going to the chiropractor. So let's see what we can do. Anyway, long story short, helped him out. Kid's ear infections went away and stayed away, and he started referring all of his friends because the young parents have other friends who are young parents with their kids, and often chronic ear infection. So I had a little boom in the practice there with young kids, and then I had another boom in the practice with infertility. You say, well, how did you even get into the infertility? Again, unsolicited, a patient comes in. He actually lived in the neighborhood where my practice was in front of. He goes, hey, I read somewhere that chiropractors can work with patients with infertility. We're having trouble getting pregnant. I said, well, okay, come on in. Explained to them how the nervous system works, how there are different aspects of pregnancy that could be affected with subluxations, and I cover that a little bit in the next lecture in our case studies. Long story short, we helped and assisted in the couple conceiving, and they started telling their friends, and then we had 5 couples in total referred to us through the same network of friends for chiropractic for some sort of infertility issue on the mom side, not the dad side, because the men were all checked in, they were fertile. And all but one of the couples conceived successfully. One did not. They ended up doing in vitro, and they ended up having twins. So I went from having 2 patients to 4 patients in that family. So it worked out. But we'll cover more on pregnancy and chiropractic in the next lecture. Have a great day. See you in the next video.